Thanks to the focus on regular screenings and early detection, many women are surviving breast cancer. Yet there is still a lot of confusion regarding screening and treatment options.
On this week's Health Talk, two highly accomplished breast surgeons will discuss the most common misconceptions and myths about breast cancer diagnosis and treatment.
So stay tuned. We're up next. Hello, I'm Dr. Vicki Smilow.
And I'm Dr. Eric Mazer. Today we're going to discuss breast cancer with Dr. Valerie Staradub. How'd I do? Good. and Dr. Jeanne Capasse, both breast surgeons. And we're going to talk about misconceptions, which I think are really an interesting topic because there are so many misconceptions out there about diagnosis and mammogram.
And there's so much information out there, Eric. I mean, you go on the internet and you can read all sorts of different things depending on where you choose to.
You can read almost anything you want to read if you look. So let's talk a little bit about mammography. It's been around a long time. We still argue about when it should be started and everything. But women come in and they say, well, I've had a mammogram, how could I have breast cancer?
They do. Women frequently ask us that, or I've had my mammogram every year, how do I have something this year? And we tell them that mammograms are watching for breast cancer, and that's actually what we're looking for. Mammogram doesn't prevent anything, it's just our best way to watch people as they go forward.
So is that then a misconception that women truly think that just because you're doing, I guess not just because, but you're doing your part, right? You're keeping up your end of the bargain of, hey, I'm doing this every year. How did this happen?
And it does, and people wonder if they had gotten screened sooner or more often, but the screening is just the looking. There are other things that people can do to modify their risk for breast cancer. Screening watches but doesn't modify. There's some healthy lifestyle options that you can choose that will help reduce your risk.
Yeah, maybe we could talk. There are always the things that people don't like to hear, like losing weight and exercise. But what are the things that people can do to limit their risk of breast cancer that are real?
Lifestyle modifications are very important. Being at a healthy weight is important. Being overweight definitely is associated with a higher risk for breast cancer.
Why is that? Tell us the chemistry behind it,
Well,
because there's
probably
a specific reason.
Higher levels of circulating estrogens from having fatty tissue.
The fat out there converts random hormones, not random ones, but to non-estrogenic hormones to estrogens. So.
Exactly.
But the point is there's a science behind this. This isn't just us telling people.
My understanding too is lifestyle changes happen are useful after the diagnosis as well in terms of preventing recurrence and prolonging life.
Absolutely.
They can help people get through their treatment, and they can also help afterwards in terms of lowering recurrence and improving survival. Things like exercise, good diet, moderate alcohol, which for women is less than men. We get a little bum rap on that.
But that's got an enzymatic basis as well, that women detoxify alcohol differently and more slowly than men. So.
Yet it feels like we need it more than men, doesn't it? That's the grand irony, or at least I'll speak for my gender.
I won't say a word to any of that.
So those are some good guidelines, right, for prevention. Obviously, get your mammogram.
How about birth control pills and supplemental estrogen after menopause? What do you tell people?
That's a good question. There's really no data that at today's low doses of birth control pills that there's an increased risk for breast cancer. Taking estrogen replacement after menopause, though, when it's combined estrogen and progesterone, does definitely increase the risk for breast cancer. So.
And birth control pills, at least I recall, also may reduce the risk of ovarian cancer, sort of secondarily. Now, that's a lower frequency disease, so you don't take it prophylactically in many instances. And actually, just to get a little bit off on a tangent, there are actually some medicines now that can prevent breast cancer in high-risk individuals, aren't there?
We like to say reduce the risk.
That's a better way, actually. Because you're right, you can't, for any one individual, you can't guarantee
You can't guarantee that it will prevent it, but it can reduce the risk for developing breast cancer by at least half with some of the medications that you can use right now. The lifestyle modifications make an important benefit as well, so the two of them together can really have an impact.
And these medications are what exactly?
There's a couple of classes of medications that can either reduce the levels of estrogen or reduce the effects of the estrogen on the body. Things like tamoxifen, which is used to treat breast cancer, aromatase inhibitors also used to treat breast cancer, and raloxifene, which is actually used to treat osteoporosis first.
Okay.
Yeah, that's kind of a win-win for a lot of women who
Yeah.
are postmenopausal, because if they have some osteopenia or osteoporosis, they can take raloxifene and reduce their risk for breast cancer and improve their osteopenia or osteoporosis.
We used to give
Right.
estrogens thinking we were preventing bone disease, but it turned out that we were also promoting heart disease and promoting breast cancer, so that's pretty much fallen out of practice at this point. But other misconceptions, because I think as doctors, as an oncologist, as surgical breast surgeons, we do hear a lot of things that people are surprised about. A lot of women think, well, how could I'll let you guys talk about family history.
I think the number one thing I hear is family history, Eric.
Yeah, nobody in my family's had breast cancer.
Exactly.
How could I have breast
get
cancer?
it? Exactly. But most women who are diagnosed really don't have a significant family history of breast cancer.
So
That's
worth-
really
it's-
powerful to get out there, and that's
Yeah.
why screening is so important, because it's not just those women who have the family history.
Exactly.
Yeah, I think it's important. Family history increases your
Right.
risk
Puts you in a
of
different
breast
category
cancer,
immediately.
but not having a family history doesn't eliminate your risk of breast cancer. I think
Exactly.
people have made that thought, and it's wrong.
The specifics of the family history matter too. People think, oh, both my grandmothers had breast cancer, so I'm at an increased risk, but those aren't in the same side of your family most of the time. And so,
I'm trying to think where they would be on the same side of the family.
I guess if you had brothers married sisters or sisters married brothers
I guess
along
so.
the way. But it matters, if there's women concentrated in one side of the family. And similarly, people have the idea that it skips a generation. So my grandmother had it, my mother didn't, so I will. And that's not necessarily the case.
Isn't it true
either.
that the first-degree relatives, i.e. siblings, mother, and children, which is not, are the strongest predictors of breast cancer?
Not always. If you have, on your father's side, aunts are considered second-degree relatives. So if your father had 8 sisters and they all had breast cancer, that's probably a bigger concern than one mother who had breast cancer at an older age.
That's
So we want to
interesting.
know both sides of the family history,
Yeah.
not just the mother's side.
And the age of onset is significant also in the family member? Talk
The
a
age
little
of
bit about that.
onset, younger aged women. When we talk about this, we're really looking for the genetically based breast
Yes.
cancer. So age of onset, or people with multiple cancers like breast and ovarian cancer in the same person. There are some other cancers like people with pancreatic cancers, some types of brain cancers. There's clusters of different types of cancer in the same family that may send up a red flag.
And let's not forget about male breast cancer also. While breast cancer is very uncommon in men, if you have a male in your family who's had breast cancer, that definitely puts you at risk as well.
Yeah, they were often carriers of one of the BRCA BRCA genes that people have heard about. So, yeah, that's a really
Exactly.
important issue. Male breast cancer is so unusual that if it's there, it should raise a red flag.
But conversely then, do we think about men differently if they're born into families where there are first-degree female relatives with breast cancer, or we don't think about them that way? I'm just curious now that we're kind of doing this.
Do you mean when we screen them?
Would we screen them, right? Would we do genetic screening for?
Yes,
or
and families where there are carriers of BRCA mutations, either BRCA1 and 2, the men can be tested. Now they have a higher risk of breast cancer, but their risk is still not very high,
It's
so
still
they
pretty low.
wouldn't necessarily get routine imaging, but
But
certainly.
they also could know that they had a higher risk of prostate or other cancers with
Right.
some of the genes as well. So they may want to be screened for other things as well.
Right.
Okay.
That's important when they're having children too, to know.
Sure. No, that's really useful information to have.
How about injuring your breast? I bumped it, and therefore that injury is going to give me breast cancer. And they maybe even talk about pain in breast cancer. It doesn't hurt, so it's not breast cancer. These are misconceptions, so let me throw them out.
Yes. Yeah.
So injury, sometimes people will say, well, I bumped my breast and then I found a lump and the lump was a cancer, but the injury doesn't cause the cancer. Sometimes it's just why you put the hand there to notice it. So that hasn't been shown to be an issue.
How about pain?
And breast pain is usually not related to cancer. So, people often say, oh, I have this pain and I'm so worried. But we evaluate anybody with breast pain, any symptoms, any symptoms at all, you should bring to the attention of your doctor. And pain that's persistent and doesn't go away, we would evaluate.
Yeah, it could be a
also.
significant problem. It's not likely cancer, but it could be a significant problem.
Sure.
And we don't want
Exactly.
people to ignore symptoms because they just had a normal mammogram. We've had people come
Yes.
in with a lump and say, well, if it was something, they would have seen it on the mammogram, and that may or may not be the case. So
Yeah,
a normal mammogram.
That's a good point, and I think a lot of people don't realize that mammograms can miss breast cancer, particularly in certain areas of the breast, which are hard to image, or certain breasts that are difficult to image.
And maybe we can talk about that, breast density, and so there's maybe some misconceptions around what the best diagnostic modality might be. So is an ultrasound better, coupled with an MRI, as opposed to having a conventional mammogram? Who should get what?
Good question.
I think let's throw digital mammography out there too, or kind of the CT equivalent where they do the layers. Because there are so many diagnostic techniques out there. What should women be looking for?
Yeah, so women of appropriate age should be getting mammograms. That's the tried and true. That's a method that's been shown to reduce mortality from breast cancer. Women who have dense breast tissue may benefit from additional screening because their mammograms are not going to be as sensitive. So for women who are not at high risk, an ultrasound is appropriate to add to the mammogram to get more information.
And by the way, dense breasts are not a sign of illness necessarily.
Correct.
Usually frequently they're a sign of young and healthy breast tissue.
In Connecticut, I guess, because don't we have this law that someone who has dense breasts has to get an ultrasound afterwards?
It doesn't actually say you have to. It says that you should have a discussion about your risk factors and about what they see with your doctor to make a decision about whether you should pursue extra. And it's meant to be extra. I'll have people hear that as mammograms don't work in women with dense breasts, and mammogram is still our gold standard. We're talking about additional screening for appropriate women, not a substitute.
And you said dense breast is normal, and particularly often indicating younger women, because what we're seeing in old breasts are fatty tissue, when young breasts don't have that as much.
Exactly.
In general, yeah. So the people hear dense as a bad thing, and it's the normal texture of their breast. It just happens to be a little more difficult to see through on a mammogram.
How about MRIs?
Yeah, I was just going to ask that.
We try to save MRIs for the highest risk women. Right now, it's recommended for women who have over a 20% lifetime risk of breast cancer, and that risk is calculated based mostly on family history. So women who have a lot of family history, a woman who's had an atypical biopsy in the past, there's a number of risk factors where we might suggest to somebody with dense tissue that they also get a screening MRI.
But if that's more accurate, why wouldn't every woman get an MRI?
Not necessarily more accurate.
Right.
The pro and the con of the MRI scan's the same thing. It's really, really sensitive, which sounds great because it can see all kinds of stuff. But lots of stuff happens in the breast that can be completely normal, and it's not as good as telling the difference.
That's interesting.
So usually you end up
you get
needing
a lot of
to have
noise.
a biopsy or something like that, or a follow-up study to figure it out. They're not better, they're not more accurate. We still
And that's true of so many of our tests today. That,
It is.
They're so accurate that you find things if you look.
And they're a lot more expensive also, and more time consuming and whatnot.
you have to have an IV with some dye injected for that study that you don't have to have for the
so
other
it's a good
imaging
example
studies.
of how more isn't necessarily better.
Right.
Correct.
So
Because
do
we tend to fall
And maybe
into
that's
that
a good
pattern
note
of,
to end on, because I think a lot of patients always think more is better. More treatment is better, more diagnosis is better, more blood work is better. And thank you. We'll be back to the short break and try to convince you that more is not always better, even in breast surgery. Hi, Vicki and I are back with Dr. Valerie Staradub and Dr. Jeanne Capasse. We're talking about misconceptions about breast cancer. I think that we talked a little bit about more is better, so that's a perfect segue into breast surgery. I remember the days when the Halsted radical mastectomy, which was took off the breast, they took off the underlying muscle, they took off all the lymph nodes and anything they could get their hands on in the vicinity, and it was really disfiguring. And now we're not doing that surgery anymore, but are women uncomfortable doing less surgery because they're afraid you're leaving cancer behind?
I think when they named lumpectomy plus radiation breast conserving therapy, a lot of our patients come in and say, well, I don't want to be conservative, I want to be aggressive. And what not everybody realizes is that those are medically equivalent treatments. People will do just as well in terms of survival and fairly equivalently in terms of cancer coming back in the same breast. We consider those to be medically equivalent.
Meaning the risk is not reduced by doing the deforming surgery. And I think that's a really important point to
Survival is exactly the same.
It took a while to convince the surgeons of that too.
Yes,
but
that's true.
most people,
Yeah.
it's pretty well, I hope, done now that we understand that lumpectomy, and now they don't.
It's also interesting, I'm sorry to interrupt you, but the psychology of it, or the semantics around it, I mean, you made a good point. You said, you know, it was called, or it's still called, breast conserving surgery, and yet to someone who's hearing it as a layperson, I would, and even as a medical person, I'd react the same way and say, no, I want to be as aggressive as possible. So, you know, the choosing of what you call things is really important.
They probably should have named it something different.
Yeah, they probably should have named it different.
We do some things that may seem also counterintuitive to people at home. People with the BRCA gene may get bilateral mastectomies. Angelina Jolie, I think, got bilateral mastectomies, and she didn't even have cancer, or maybe she did. But just as a prevent, thank you, she didn't.
She said she didn't. I didn't take care of her.
I don't. No, I'm using. I'm not violating HIPAA. I have no idea other than what I read in the tabloids.
She didn't. Yeah. And if you have a cancer that you can find and remove, we can treat you just as well by removing the tumor as by removing the breast. She did it to prevent a cancer. Once you have a breast cancer, there's a risk from that cancer, and her goal was to prevent herself from ever having that risk.
Yeah.
Similarly, people take that to think there's a trend in this country right now for bilateral mastectomy for treatment because people think, well, if Angelina did it, it must be better. And if you're treating a breast cancer on one side, the risk you have comes from the cancer you already have, not from one you probably will never get. So you actually don't buy yourself any extra days on earth by removing the other side as a risk-reducing measure.
And along the same lines, lymph node sparing surgery. Again, even early in my career, we pretty much did a total axillary dissection on every breast cancer patient, and we've learned that's not necessary either. But
now, instead of removing most of the lymph nodes in the underarm area, we do something called a sentinel node biopsy, which is a way to map where would cancer spread if it was going to spread to the lymph nodes. And so we can really limit the number of lymph nodes that we remove. And even if there is some cancer in those sentinel nodes, there's good data now that most of the time we do not need to remove more lymph nodes at the time of surgery. And this has been great because the risk of lymphedema, of swelling in the arm after removing those lymph nodes.
That was a horrible side effect.
So
how do women respond to when you present them with these, what are better options, right, cosmetically and in terms of everything? Is there still hesitation? Are women still of that mindset that, more is better?
It takes a lot of education.
Yeah.
People oftentimes, and I'm sure you see the same thing, come in and say, well, I've always said if I ever had breast cancer, I was just going to, people say, have them both off. They all go like this. But you spend an hour and a half, 2 hours with them, and you talk about the data and the fact that, they're equally valid treatments. You can do that. But what are you gaining for yourself versus what are you giving up or losing? And if you do a bilateral mastectomy, you double the surgical risks. If you remove more lymph nodes, because you chose to do that, you do take the risks of swelling in the arm, of uncomfortable sensations, of sometimes people have tingling or range of motion limitations. So what we try to do is educate people that we use our data to try to do exactly what we have to do, not over or under treat, with the same outcomes in terms of benefits that our older treatments gave us, but fewer of the side effects.
Yeah, and it is a discussion because it's a very personalized treatment approach. And I think when things vary is when you have somebody who has a strong family history or has gone through multiple benign biopsies in the past. Many times after a diagnosis of breast cancer, sometimes the decision on their part to have a mastectomy is not because they think they'll do better, but because they don't want to have mammograms anymore and risk the need for biopsies. So it's really a discussion and education. But for most women, a lumpectomy is the approach that's best. It's the least invasive and really offers the same survivals.
And you need to ask them why, because I personally have a lot of women that say, well, because if I have more surgery, I can get out of chemotherapy. And it just doesn't work that way. Chemotherapy's job, if they want to give it to you, is to protect the whole rest of your body.
Yeah.
And we're pretty good surgeons, but we can't do that. So
Yeah,
you
breast
want to make
cancer, I
sure.
guess maybe to just discuss the biology of the disease a little bit. If cells break off and get planted elsewhere in the body, we may not be able to detect them till they're a half an inch or a quarter of an inch in size, or even larger.
Right.
And we know that there's risk for that. The larger the breast tumor, the more lymph nodes are involved, certain things about the breast cancer.
So you need the chemotherapy.
What the
Or
chemotherapy
something
does
else.
is sort of kill those cells we don't know about in patients who are at risk.
And sometimes you can use the chemotherapy or the hormone blocking therapy. And just like with the surgical treatments, we're having more and more data to tell us how we can tailor the treatment to the individual person. So people think breast cancer treatment is this, but breast cancer treatment varies a lot with the woman and her individual tumor.
And we now can do genetic profiling on the tumors and everything
Exactly.
that really changes those decisions. So there's really a very personal decision that's made for the whole variety of different breast cancer types and risk profiles.
That's exactly right. Yeah, just because you have an invasive breast cancer now, chemotherapy is not necessarily
And
indicated.
one
in
your
fewer
breast
and
cancer
fewer.
isn't your mother's or your neighbor's breast cancer. They are
Yeah.
different diseases.
Yeah.
And I think we suffer a little bit by using the word cancer or breast cancer because people tend to consolidate them, and we're really learning that these are breast cancers, lung cancers, that they're different
They're different
biologically,
types,
that they're
yeah.
required to. There's something I used to experience with as an oncologist is I give chemotherapy, and if the patients didn't get sick, they thought it wasn't working. And I used to be pretty good at using drugs to prevent the illness, the side effects.
Yeah.
So, but that's another sign that's wrong. You don't have to get sick. We're trying to prevent you from getting sick.
Right.
We don't
Right.
want you to get sick.
Right.
Is that, I wonder, does that ever come up as, I mean, I can
It's
see
sort of
what
more.
you're saying.
There's this again. I'd like you to speak to this, but somehow people feel they need to suffer in order to cure
order
the
to get better,
disease.
right.
I think
to
where
fight the disease, you've got to be.
Yes.
And I think if they can walk away with a lumpectomy and a little bit of hormone suppressant therapy, and they walk away feeling quite well, they may feel they haven't done enough.
There's a lot of advocacy around breast cancer and breast cancer treatment, which I think is wonderful, but it does sometimes make things very public in a way that somebody who doesn't experience it the same way might be concerned
Yes.
about that. So I think a lot of our advocate groups are starting to send the message that this is you and questions you should ask your doctor and tailor your therapy.
Yeah.
A lot of the sheets of things that people come in with now that they've gotten from websites or things like that have started tailoring the questions a little bit more. So I do think that's getting out there, that it's a broad category of thing. Like you said, I agree completely. We should call it breast cancers.
Yeah.
Or one of the family of breast cancers.
Right.
Yeah.
They're all so different.
They're different. I wonder, we talked about mastectomies and women coming in and saying just lop them off because I don't want to have to worry about it. Do you think that also stems a lot from the advances in reconstructive surgery options? Because it's not disfiguring like it used to be, right? So now I
Yeah.
can sort of see that. And,
Well,
and I have a
maybe
good
that's the
friend
whole
of
point.
mine who actually said this to me recently, if I ever had, or even I think her mom was just diagnosed, and she said, I'm really thinking about just having them removed and getting, new fake ones, and everything will be great because then I won't have to worry about it anymore. So maybe you can speak to that a little
It's a
bit.
good question, and that is something that we hear a lot. But a reconstructed breast is not a natural breast. There's no sensation in it, and
Right.
while the techniques are excellent, it's not always the result that a woman might be hoping for. And so I think it's important to realize that if you're going to lose your breast, you're really going to lose your breast.
Yeah.
And it's also important to realize that having a bilateral mastectomy does not eliminate the risk of getting breast cancer. There is still a small risk that you could
It
get breast
reduces it,
cancer.
does it not?
Oh, it significantly
Significantly
reduces
reduces
it.
it.
It's the
We've
most
proven that for the
risk-reducing
BRCA
thing you can
patients.
do, but it's not 100% protection.
And I think another one of the misconceptions is that, breast implants are breast implants like you see on the celebrities in television. Breast implants after mastectomy are different. There's not the normal healthy breast tissue over it. You can feel them. You can see the edges sometimes. You can see the ripples. They don't
That's a good
feel like breast tissue when you touch them. And some people have, discomfort with them, or they can be heavy.
Yeah.
So reconstruction is an option, but it is not a lifesaver, if you will. It's one option for someone to consider. And we've run out of time, so you can't even answer that.
So we covered a lot of misconceptions, so we want to thank you. This was actually a really good discussion.
I want to thank Valerie and Jeanne for joining us on the show. This was it was their idea for the topic. I think it's wonderful. And Vicki and I will be back after this quick break.
Right now, let's take a look at some of our future events sponsored by Western Connecticut Health Network.
Welcome back to Health Talk. We're going to have a little bit different ending today. It's a bit of a sad time for me. Vicki Smitak is leaving us after this show, and she is moving on to new and greater things. She's taken the job as a chief medical officer at a children's hospital in San Antonio. It's a great job. I want to just let everybody know at home how much I have enjoyed getting to know Vicki over these past 3.5 years, working closely with her over these 3.5 years, and learning with her. It's really been a great experience. So Vicki, congratulations on your new position.
Thank you,
and good luck, and I will miss you terribly.
I will miss you
and
too.
We'll try to find somebody else, but we won't find a replacement.
Oh, that is so kind. It has been an absolutely wonderful experience for me these past 3+ years, and I'm going to try not to get emotional as we wrap this up, but it has been absolutely wonderful. I've learned a lot from you, and
from you, having a pediatrician as a co-host was really wonderful, because I think it really helped change our focus or expand our focus. So we were talking more about children and what parents wanted at home. So
yeah, we did some good things together, and I'm going to miss you.
Thanks, Vicki. We'll miss you a lot. And I also want to thank both of our guests today, Dr. Valerie Staradub and Dr. Jeanne Capasse, for coming on our show. Great topic. And we will see you next week. I guess I will see you next week on Health Talk. Bye-bye.
Goodbye.